Hello, my name is Michele Weaver. I'm a physical therapist at Spectrum Health. I'll be speaking with you today on the importance of physical and occupational therapy and the management of multiple system atrophy. The presenters have no conflicts of interest to report. Today, my objectives for physical therapy are that you'll understand how MSA differs from Parkinson's disease and Parkinsonism. Identify your rehabilitation team and their respective roles. Understand the benefits of exercise with MSA. Learn the different types and intensity of exercise. Learn modifications to your daily routine and exercise programs, and understand how mobility aids can improve your energy levels and safety. As we know, multiple system atrophy is a progressive neurodegenerative disorder characterized by a variable combination of autonomic failure, levodopa or medication unresponsive Parkinsonism, cerebellar ataxia, and pyramidal symptoms. Motor symptoms often include tremor, rigidity, and loss of muscle coordination, as well as difficulty with speech and gait, or difficulty with walking, mimicking those of Parkinson's disease and ataxia. Other than autonomic failure and motor symptoms, non-motor symptoms, including stridor, rapid eye movement, sleep behavior disorder, pseudobulbar effect, which is difficulty controlling emotions, laughing or crying at inappropriate times, and severe dysphonia and dysarthria are often seen in MSA. Some of these features are similar to those seen in Parkinson's disease, and early in the disease course, it may be difficult to distinguish between the two. MSA presentations can come across in one of three different ways or a combination. They can be seen as Parkinsonism, which is slow and stiff movements, soft speech, and frequent falls. Cerebellar ataxia is characterized by irregular movements, trouble walking in straight lines, limb tremors, and frequent falls. Or what some may be experiencing often is autonomic nervous system symptoms, such as bladder incontinence, drop in blood pressure when moving from lying or sitting to standing, and loss of sweating. There is no definitive diagnostic test for MSA, and in its early stages, symptoms can often share similarities to those of patients with other neurological conditions. Sadly, this means that diagnosis or misdiagnosis is not uncommon. Some of you may have experienced this. Atypical Parkinsonism, or Parkinson's plus, refers to conditions that have similar symptoms to Parkinson's. These symptoms, such as tremor, slowness, and stiffness, are called Parkinsonism. People with atypical Parkinsonism may look like they have Parkinson's, but they often have additional symptoms that are not common in Parkinson's. The symptoms may progress more quickly and benefit less from medications used to treat Parkinson's disease. Some of these Parkinson's plus syndromes include progressive supranuclear palsy, MSA, and that can be including Shy-Drager syndrome, striatonigral degeneration, and olivopontocerebellar atrophy, which are now all included under that umbrella of MSA, corticobasal ganglionic degeneration, dementia with Lewy bodies, and vascular and drug-induced Parkinsonism. Because there is no cure for MSA, treatment is focused on improving the symptoms and quality of life. Treatment can ease the symptoms of atypical Parkinsonisms, and because the symptoms overlap across all of these conditions, including MSA, the treatments can overlap too. And that's why I find it important that we understand that MSA, Parkinsonism, and Parkinson's plus syndromes can work together and the treatments can overlap. Being involved in a multidisciplinary team can be very helpful. Here at Spectrum Health, our multidisciplinary team includes a physician, a nurse navigator, a pharmacist, a social worker or psychologist, and our rehabilitation team of an occupational and physical therapist and a speech-language pathologist. Very often, some other multidisciplinary teams can also include a dietitian. Now, I hope many of you had already had some experience with a physical therapist. In general, physical therapy is going to emphasize gross mobility skills, including moving from sitting to standing, walking, getting from one room of your house to another. Think about how you want to move around outside and in your community. Or perhaps you have really ideal goals of playing with your grandkids that are quite specific, maybe getting back to riding a bike. Your therapist is going to work with you on your specific needs. What do you need to do to move more efficiently at work or out in the yard? Do you find that you have a more challenging time walking out in your yard versus in your kitchen? Your physical therapist is part of your team. They work with you to set your individual goals based on your interests, your current abilities, your support system, and your prognosis. Our ultimate goal as your physical therapist is to keep you moving safely and as independently in and about your home and within the community for as long as possible. Now, how do we go about doing that? Exercise. Now, Grumpy Cat here has it right when you don't want to work out, but you do it anyway because it has many benefits. And that's the truth. Now, much of the research on exercise and movement disorders is on patients with Parkinson's disease and Parkinsonism. There are few limited case studies specifically for patients with MSA, but the incidence of people with MSA is quite small in comparison, and that's why. We have many larger studies, systematic reviews, and meta-analyses, including patients with Parkinson's disease and Parkinsonism. As mentioned earlier with MSA, we treat the symptoms, and because symptoms overlap across these conditions, the treatments overlap too. With that said, let's move on to the findings. Aerobic exercise has generic health benefits for people with Parkinsonism, including those with MSA, such as reduced incidence of cardiovascular disease, a lower mortality, and improved bone health. Additionally, there is evidence that aerobic exercise improves physical fitness, or your VO2 max, and attenuates motor symptoms, improving the MDS-UPDRS motor section in the off-medication state. And that's how we do our testing, ideally. Although the long-term effects beyond 6 months continues to be unclear. Other improvements are increased walking speed, and this is something we often measure in physical therapy. Improved mobility, such as rising to stand, turning around in close quarters, and walking short distances. Increased BDNF, or brain-derived neurotrophic factor, which promotes the survival of brain cells. And we all need this. This isn't just for people that have neurodegenerative diseases, but everybody of all ages wants to improve their BDNF. And improvements in walking speed isn't just important because we want to walk fast, but what we found is that when people are able to walk at a faster speed, they're at a decreased fall risk and their balance is improved. And when you are at a decreased fall risk, you're less likely to fall and break a hip, you're less likely to fall and get a head injury. And the last thing we need on top of a neurodegenerative disorder is a musculoskeletal injury or a brain injury. So let's be safe and do some exercise. Now, as far as types of exercise, there are many different types of exercise. And I'm sure when you think of exercise, you may be thinking, I'm already tired, or perhaps I'm already active throughout my day. I clean the house, I run errands, I have children to take care of, or I already watch my grandchildren. But unless those activities are set apart from your day as purposeful and intentional times to improve your function and meet your identified goals, they're not classified as exercise. At best, you're being active. And I'm very proud to have you do that. The most effective exercise intervention has yet to be revealed, and there is a real need for well-designed, controlled clinical trials that compare and/or combine different modes of exercise. Different forms of exercise that you may be familiar with include resistance training. So that's using exercise bands, lifting weights, or using machines at the gym. Cardiovascular or aerobic training. Think of walking or running on a treadmill or going outside. Bicycling, perhaps pedaling for Parkinson's, you may have heard. Using the elliptical. It's really breaking a sweat as your cardiovascular or aerobic training. Stretching, and this can help keep your joints and muscles limber and prevent contractures. Balance exercises. These may be done in a corner or next to a counter to help you use your ankles and hips, perhaps even taking a step to help keep you safe and prevent falls. You may have also heard of amplitude-oriented training, such as LSVT big or boxing, rock steady boxing. Lastly, Tai Chi, and this is a Chinese martial art form with slow dance-like movements that work on your breathing, balance, joint range of motion and flexibility, strength, and endurance. Some exercise regimens have been specifically directed toward people with Parkinsonism or MSA. The LSVT BIG is an intensive, effective one-on-one treatment created to help people with Parkinson's disease and other neurological conditions address walking, balance, and other activities of daily life, such as writing, dressing, and getting up from low chairs, or even job-related tasks. Our therapist that's speaking later, Kerri Vryhof, she's LSVT certified. These sessions include 60-minute sessions, 4 days per week for 4 weeks while in therapy. The participants are also expected to perform their exercises an additional time outside of therapy. So they're performing their exercises twice a day. And after the conclusion of their 4-week therapy session, they are to continue their exercises. So it's ongoing therapy. Rock steady boxing includes exercises are largely adapted from boxing drills. The boxer is conditioned for optimal agility, speed, muscular endurance, accuracy, hand-eye coordination, footwork, and overall strength to defend against and overcome opponents. Rock steady boxing, again, is focused on Parkinson's disease, and they believe that the opponent is Parkinson's. The exercises vary in purpose and form, but share one common trait. They are rigorous and intended to extend the perceived capabilities of the participant. Pedaling for Parkinson's is a form of forced exercise. And you'll hear that again on the next slide, forced exercise, on an indoor stationary bicycle designed specifically for people with Parkinson's disease. The participants ride for 60 minutes 3 times a week. They have a 10-minute warm-up at about 60 RPMs, followed by a 40-minute session at 80 to 90 RPMs, and RPMs means revolutions per minute, followed by a 10-minute cool down. Again, there is no clear evidence that one mode of exercise is superior to another. But the mechanisms underlying these exercise-induced changes are not quite yet understood. What is found, however, is that intensity matters. Exercise intensity is more important than the type of exercise in mitigating motor symptoms of Parkinson's disease and Parkinsonism. One particular study by Arkelin and colleagues reported that treadmill and cycling training at similar intensities resulted in comparable results in improvements in gait, mobility, and balance. Collectively, these results indicate that high-intensity exercise, which is defined against most studies at greater than 60%, up to 80% of your heart rate reserve, and we use the Carbonin method, can be delivered via multiple modes to result in global improvements in motor function. Now, endurance alone at lower intensities, which is less than 60% of your heart rate reserve, was not found beneficial. So this may mean your stroll in the park for 40 minutes or your leisurely walk, unfortunately, did not show any significant improvement in motor function or non-motor features of Parkinsonism. The exercises must be forced, not voluntary, meaning self-paced, and the intensity needs to be high. Studies also conclude that low doses of physical and occupational therapy do not improve outcomes. Lastly, a nice point to make is that the benefits of high-intensity exercise are found during the therapy period, which for most cases in most studies is about 8 weeks. But most of the studies also found that the benefits can continue for 4 weeks after the end of therapy. So isn't it great to think that if you can work hard for 8 weeks, you can even have extended benefits? Now just imagine what we can do if we continue our regimen of high-intensity exercise for 3 to 4 times a week. And again, I just want to reiterate, I know a lot of these studies are focusing on Parkinson's disease and Parkinsonism, but because the symptoms overlap and that's what we're treating, the treatments overlap too. And I do realize as much as exercise has a myriad of benefits, I also want to be sensitive to the potential barriers. With the progression of MSA, patients may develop varying degrees of motor and non-motor complications, such as motor fluctuations, increasing dysautonomia, dyskinesias, unpredictable response to medications, increased fall risk, and depression. There's also a lack of access to individual therapies, perhaps due to living in rural communities, access with your insurance, not having equipment within your home or community, or unfortunately being confined to your home due to our current pandemic situation, or even challenges with support network. All of this can make sustaining an exercise program a barrier. Another common barrier that's experienced specifically with MSA is orthostatic hypotension, and it's a common complication. Modifications to tolerate exercise can include compression stockings, and these can easily be added. We can use knee highs, thigh highs, and for a lot of women that can tolerate it, we can even use pantyhose that go up even higher. Now, with prescription compression stockings, these are also graded. So we can start with a class 1, as long as you have the hand strength or a support person that can help you put them on, and they can even go up to a class 3 compression. Performing these exercises in a seated position, reclined, or even in a supine position can be done, particularly with the LSVT program, and cycling can be done not just at a stationary bike, but moving more toward a reclined or recumbent bike can be done. We can do isometric exercises prior to changing in position. Isometric exercises tend to increase the blood pressure, so doing those prior to changing position can also be helpful. And use of the Valsalva maneuver can also help increase that blood pressure prior to changing positions. And as much as we want you to exercise and keep yourself healthy and independent for as long as possible, I also want to make sure you are as safe as possible. At times that may mean adding a cane or a walker to increase your footprint, or as we call in therapy, your base of support. This will make you more steady and also use less energy. Similar to the feeling of security you may have when you're pushing the grocery cart at the supermarket. Everyone feels more supported when they get to use that large cart. A wheelchair is also another brave option. And yes, I said brave. It takes courage to realize that you may have to ask for help at some point, and you can give yourself a little grace. Not because you haven't given it your all, and because at some point your body just may need a rest. When it gets to that point, it's okay. There are some walkers, like this one that I have pictured, that are able to tolerate some accessories. So when you are able to do your walking and you've been able to work hard for that day, and now it's time to take a rest, or you're suddenly feeling a little lightheaded, perhaps you didn't take enough salt tablets that day, or you didn't drink enough water, and now it's time to take a seat. You can have a seat on your four-wheeled walker with the seat, or you can have a seat in your wheelchair and somebody else can give you a ride. Another brave option, I believe, is power mobility. It allows you to get from point A to point B safely. It gives you less risk for falling. And just because you have a power chair, it doesn't mean that you can't walk. It again is an option for you on days when you may not be feeling your best. Or perhaps it gives you more independence when you are left home alone for a short period of time, giving your family the option to go out and run some errands and have that peace of mind knowing that you are safe home alone. It can also be used to help you conserve energy so you can do other things throughout the day. Mechanical lifts, like Hoyers and hospital beds, are also helpful options to learn to use with your therapist to make you feel more comfortable and help you transition slowly from one position to the next. This slide here is just some resources for you for exercises for the LSVT Global website to find specific therapists that are certified in LSVT Big. Pedaling for Parkinson's, which is that 3 times a week for 1-hour sessions, and Rock Steady Boxing. And that top link there is for finding APTA certified neurological therapists that may have more experience with patients who have MSA. In conclusion, I want to make sure you engage your rehabilitation team. If you have the opportunity to be part of a multidisciplinary clinic, be engaged with them. They are there to help you. When you have concerns or questions, changes in your symptoms or abilities, this is when you reach out to your team. They are there for you and part of your support network. We cannot cure MSA, but exercise can help treat the motor symptoms of MSA. You must exercise at higher intensity to get the benefits. This can help with motor symptoms you experience with MSA. Moving about your house and doing chores will not suffice. The exercises must be hard, purposeful, and forced. But you must remain safe. Make the modifications to your daily routine and exercise programs to enhance your participation. Include compression socks, modifications to your routines, do them in sitting, reclined positions, or supine when it becomes time. Mobility aids can help. When the time comes and you need more help to remain safe, to prevent a fall, and keep your independence, using a walker or a wheelchair is a smart choice. Power mobility is also a brave choice. It does not mean you cannot walk. You are choosing to put your safety and your family's peace of mind first. And this is something I always like to tell my patients, regardless of their neurological diagnoses. What doesn't challenge you doesn't change you. Thank you for your time.
Hello, thank you for joining us today in this rather unique presentation format. My name is Kerri Vryhof, and I'm an occupational therapist who has been practicing for more than 25 years. Occupational therapy is a field that I love and have enjoyed as a career choice. Many people have never heard of or don't know very much about occupational therapy. So my first slide leads with that. What is it? What is occupational therapy? Well, it's a process of working towards health and well-being by participating in occupation and engaging with things that matter to you. Occupational therapy in some ways is about doing what you do. The first slide lists off some of the core beliefs, showing that there's a positive relationship between occupation, what you do, and your health. It also asserts that people are occupational beings, so that engagement and involvement in doing things makes a difference in your life. It contributes to your sense of identity and competence. Participation in occupation, in a very broad sense, much more than work, but encompassing all the activities that matter to you, that participation gives meaning to life, and it also changes over time. The next question I raise is, what do occupational therapists actually do? Well, we work to promote health, safety, and well-being by using a framework of considering the person who's sitting across from me, the person who showed up in my office for an evaluation, the tasks that that person needs or wants or is expected to do, and the environment where those tasks are done. Occupational therapists collaborate with clients and families to consider who is doing what, where. In starting with the person, I'm considering the person, as I said, who's sitting across from me for an evaluation, likely with MSA or some other movement disorder. I want to keep that client at the center of the care, looking at what matters to the client or the family. I also want to consider their current needs, what they're coming in, what brought them here for a therapy evaluation, as well as their future needs. OTs help to anticipate problems before they arise. But I'm not only treating a single person. That person comes in with perhaps a family or a support person. And so we look at what support is available and how willing are those people to be involved. How much do they understand the condition that we're dealing with? And at times, caregivers are involved in therapy sessions as well. Specific to MSA are some upper extremity, that's therapy talk for your hands and your arms. MSA might cause some specific difficulties in using your hands or your arms. Some examples are slower movements, so things take longer to get done. Tremors might lead to spilling or difficulty grasping or holding on to things. Weakness in your grip or pinch strength makes it hard to open jars or to open Ziploc bags and things like that, working in the kitchen. Hands can fatigue more quickly, especially with a repetitive task, such as chopping vegetables or stirring. So those hands can tire out more, or tasks that require you to hold your hand in one position. Another effect is that hands can become contracted where joints don't move as well, and there's some tightness in those joints. So an occupational therapist will look at how your hands and arms are working. They also might evaluate the need for a wrist or hand splint, because splinting may provide support for those weaker joints. It can also help with pain relief or increasing comfort, and splinting can provide some stretching to maintain or improve that range of motion. There are two main types of splints that occupational therapists recommend. A resting hand splint might be used at night for positioning and to allow then hand use or function during the day. A resting hand splint is a piece of molded plastic that starts mid-forearm and extends to hold your wrist in a position of slight extension. It also has a C-shaped hand piece here. So your hand is held in this position throughout the night, and that keeps your hand in a functional position, prevents it from curling up or tightening up. And those are used at night because you don't need your hands to function while you're asleep. If you have some weakness in your wrist or need some support during the day, we might recommend what's called a wrist cock-up splint, which also puts you in a bit of wrist extension. You may have seen these splints. They leave the fingers free for hand function, but they give you support at the wrist, and sometimes the angle of that support can be adjusted by a metal or a plastic stay. It's important for an occupational therapist to make some recommendations about what splints are right for you, because for the most part, we want to keep joints that are moving, and we don't want to immobilize if that is not needed. Moving on to our task element, and in talking about the person, we would delve into your routines and some things that matter to you, and it would be a more thorough assessment. But then we would also shift or move on to tasks. What things are meaningful or purposeful? What contributes to your quality of life? Occupational therapists, we have our lingo, and we refer to those as activities of daily living, or ADLs. And there's a whole continuum of basic tasks to complex and multifaceted tasks. So basic things can be as simple as feeding yourself, or basic things like brushing your teeth, shaving, showering. Those essentials, they're very important things, especially if you're having difficulty doing them, but also then can range up to some of my clients are working, and so we figure out how is work going, or how can you maintain your work life, or parenting, how can you effectively stay engaged with that. So we look at some of those roles and rituals, the routines that give structure to your life, and we also want to consider how you're completing those tasks and what's changing in your ability to complete those tasks. Part of that process at times is acknowledging some of the losses along the way. And when we talk about tasks and environment intersect when it comes to doing things. So I will talk a bit more about specific activities of daily living when we shift to our environment section. Before we do that, though, I want to mention and give a brief overview of the concept of energy conservation. We all have limited energy, even though we like to think that it's unlimited at times, but people with MSA need to think about their energy differently than they may have had to in the past. And so using these ideas, the principles listed there on the screen, can be very helpful in allowing you to stay engaged with the tasks that are meaningful to you throughout the day. So doing things like taking breaks, pacing yourself so that you alternate activity with rest, planning ahead so that you get all the things you need and have them close by when you're completing a task, rather than jumping up 3 or 4 times to get what you need. Sitting rather than standing is an energy saver. Using good posture and body mechanics are another way to save some energy. And so you want to think about how you can incorporate some of these principles into your daily routine, because people with MSA pay a higher price when they ignore those energy limits. We often use the analogy of a bank account and encourage you at the beginning of the day to think what kind of balance do you have? How much is in your account for this day? And then what are the things that will be adding to that energy? What are your deposits? And what are your withdrawals? So what will take away from the energy that you have? How will you use that energy through the course of the day? So energy conservation becomes an important issue, or an important way of allowing you to engage or stay engaged with the activities that matter to you. Michele mentioned wheelchairs as a way of saving energy, and we try to present that as a new perspective. People don't want to use a wheelchair, and I can understand that, but thinking of it as a way to save energy for being able to do something else that matters to you might help with that perspective on using a wheelchair or using a mobility aid. So now we want to move on again and talk about the environment. the third element of that OT framework of person, task, and environment. And we're looking at where are these things being done? The focus for OT, one of the focuses, is on safety. Safety and fall prevention are very important when people are moving around and doing things in their house. So we want to look at the surroundings, the environment, and how is that supporting the tasks that people are performing, that people need to do? How does the environment support? And then also, are there any barriers, or how does the environment perhaps hinder occupational performance? We also want to look at the public and private spaces within and outside of the home. So in our homes, we have places where we meet people and where we are with other people. We also have places where more private things happen. We go out into the community, we function inside the home, and we want to give that global or broad perspective. In considering the home or the residence, we need to start thinking about what changes should be made over time. Do we need to widen doorways? Are there places where grab bars or railings need to be involved? Consider the lighting and the use of night lights. How can those things enhance or support everyday life and occupational performance? As we continue to consider the environment, we're going to take a little tour, sort of a walkthrough of a typical home, and talk about safety and equipment considerations. Sometimes OTs are considered the gadget people because we have devices and things that we recommend to make life easier. So we'll talk about some of those as we make our way through a typical home. A couple other terms to keep in mind. One term is durable medical equipment. You might have heard that and wondered what in the world that is. It also is known as DME, so durable medical equipment. Those are actual pieces of equipment. A walker is a piece of DME, a bathtub bench, those kinds of more solid equipment. The other thing that OTs can recommend or provide are different adaptive devices, smaller things on a smaller scale, like a button hook or a reacher. So those terms can come up, and I wanted to make you aware of that. But starting with the entry and the exit to a home, you want to look and see what is the safest way in or out of your house. Is there more than one way out in an emergency? Are there railings available, or do they need to be placed somewhere? Is there a need for a ramp to be built or an eventual need that you might have? And once you're in the house, if you consider the living room, that public space where many people may be gathering, you want to look at clutter. Clutter is a big culprit in falls, and so you want to remove clutter, keeping clearer walkways and getting rid of the throw rugs. You also might want to look at the furniture arrangement. Is it safe? Does it allow accessibility as it needs to be? Do things need to be rearranged to make the flow better? And another piece of equipment that can make life easier and more comfortable is an electric lift chair, so that you don't have to do that hard work of transfers, or at least the assist is available when it's needed. Moving on through the house, we go to the kitchen next. And what happens in the kitchen? Well, food prep and cleanup, as well as eating. And so if we're looking at food prep and cleaning up afterwards, we want to think about the space, how well it's organized, and if there's a way to keep those more frequently used items accessible. Can you bring things down from higher cupboards? Can you keep things on the counter if you're going to be using them frequently? You also may want to consider some adaptive equipment for food prep. There are items such as Dysum. This is a non-stick pad that can be placed under a bowl or a plate so that things don't slip and slide around, or so that you can do things using one hand more easily. There also are adapted cutting boards that can be used so that things can be pushed against the edge. They have raised edges. This is a special knife. I'm not sure how well things are showing up, but I'm trying to make things as visible as possible. This knife can be used one-handed, so you can use more of a rocker movement. There also are cut-resistant gloves. So if you're needing to chop some things and you're concerned about being able to stabilize with one hand while chopping with the other, there are gloves that can cover your whole hand that will allow you to be safer with cutting. Also using covered mugs for beverages. You look at what kind of equipment people are using to make eating, the actual act of eating, easier. When it comes to that, mugs with covers or special handles that make it easier to hold on to. Longer straws can be easier to make drinks easier to manage. Also, there are different devices. This is called a scoop plate. It has a raised edge on it so that you can use your utensil to push the food against it if you tend to chase food around your plate. Another thing to keep in mind is that it's easier to hold things that have bigger handles. So this is a type of lightweight utensil, and it is built up, but it has a lighter weight to it so that you can hold it differently. You can grasp it overhand, you can grasp it more traditionally. A spoon with a bigger bowl will also generally be easier if there are no swallowing concerns with people kind of overloading things. Another device is called a universal cup, and this is a device that slips over your hand. And again, you can put a number of different things in here. For this, it fits on the hand so that you don't actually have to grasp or hold it. You can put a spoon in there, you can put a toothbrush in there, you can put a comb in there. So there are different things that this can be used for as well. Moving on again in our home tour, we come to the bathroom, and we consider the bathroom. We want to think about the fall risk because there is a high potential for falls in the bathroom. And as we think about that question, who is doing what, where, we know the things that happen in the bathroom, and it's good to kind of think of the different zones. So we might have the bathtub, the toilet, and the vanity as the zones of the bathroom. So what if we start by looking at the bathtub, what kinds of things can make bathing or showering safer? Well, a number of things can help with that. A bathtub bench or seat. There are types that fit in the tub. There are types that extend over the tub. Having some grab bars installed into the shower near the entrance or on the wall of the tub. Using a non-skid surface, a mat, or some of those decals can also be helpful. And if you have the means or the possibility of a renovation, designing a bathroom with a zero entry shower is an excellent idea. If we move on to the toilet, we want to generally try to raise the level so that people have an easier time getting on and off the toilet. Raised toilet seats may or may not be helpful. Something that we found to be more helpful requires a bit of plumbing, but it's called the toilevator, and it actually goes under the base of the toilet and can raise your toilet up by 3 or 4 inches. Another option for bathroom or toileting is something called a Versa frame commode, and that is an actual frame with arm rests on it, and that fits over the toilet so that it gives people something to push up from for toilet transfers. Again, grab bars can be helpful. Strategically placed can be helpful to assist with transfers. And if hygiene is an issue, toilet hygiene is an issue, consider a bidet. There are actually portable bidets that can be attached to the toilet to make that part of toileting easier. I listed off on the slide there a number of personal care aids. There are things like a bath mitt with a pocket for the soap so that the soap doesn't go sliding all over. There is a toilet aid or toilet tongs where you wrap the toilet paper around the device and it extends your reach for toilet hygiene. OTs get in there and get nitty-gritty with the basic things of life, and so these are the things we may end up talking about. People also use long-handled sponges to extend their reach. Flushable wipes with moistened wipes can make cleanup easier. if you put cylindrical foam on a toothbrush, or you put it on the handle of a comb or brush, anything building up the handle of anything makes it easier to hold on to. You can also put that on a pen if this is not happening in the bathroom, but if you put foam around a pen, it can make writing a bit easier. Anything that you need to hold on to, though, and if you build up the handle of it, it will generally be a little bit easier to hold on to. There also are hair dryer stands. So when it comes to holding and styling your hair, holding a hair dryer, that can become fatiguing. And so there are stands that your hair dryer could stand on. Basically, there are a lot of different gadgets. Nobody needs all of them, but it's important to begin to know what's out there and what's available. Lastly, we move on and we end up in the bedroom, where we start and end our day. What happens here? Well, sleep, which is an activity of daily living and a very important one for your health and well-being. On the slide there, I've listed some adaptive equipment that can make sleep more comfortable. It can help with positioning. Sometimes people need some padding, extra padding or pillows in their bed, a wedge to raise the height of the top of the bed, a hospital bed that is self-adjusting or that you can adjust to certain levels. Anything that helps to improve positioning or ability to move around in bed can improve the comfort there. Some people have a hard time turning or rolling over, and so using more of a slippery or silky sheet can help, or a draw sheet just under the hips can make it easier to change positions. Another recommendation that we often make, and people don't jump on this as something Another recommendation that we often make is to consider using a urinal or a bedside commode through the night so that you decrease the number of times that you have to get up and actually walk to the bathroom. And this can be helpful for the person with MSA as well as the caregiver who has to get up and help for each one of those trips to the bathroom. If we can get less disruptions to sleep, have better quality of sleep, and that usually carries over to a better day the following day. And then the other thing that happens in the bedroom is that we generally get dressed there. And there are a number of adaptive devices that help with dressing as well. Simplifying what you wear and the choices that you have, using more loose fitting or slip-on clothing also is a helpful thing. There are devices such as a button hook. You may have seen one of these before. You slip this through the buttonhole and catch the button and then just pull it through, and that helps with buttons. At the other end of this is a zipper pull. So you hook this through the zipper and it gives more leverage or more to hold on to complete zipping. There are gadgets like sock aids. You slip a sock on the end of this and pull it on, kind of go fishing for your foot, and that can make getting socks on much more easy. Using Velcro instead of ties, using Velcro buttons or adapted clothing, there are many, many options, again, that can make those everyday tasks a bit easier. So that brings me to the end of my part of the presentation, and I just want to reiterate a few points as we conclude. Your personal care and your home safety needs will change over time. There is equipment and other modifications that may help to maintain your independence, to improve your safety, or to decrease the work that a caregiver provides. And occupational therapists can collaborate to help determine the best options, because there is no one-size-fits-all gadget. And no, as I said earlier, nobody needs all of these things. So we need to figure out what works for your situation. So the who, the what, and the where matter. And OTs can help figure out some of those details of person, task, and environment. Thank you for your attention this afternoon.